Well, here I am. I'm 73 years old. I look like hell. I need a haircut. And right now, I have chronic lymphocytic leukemia. I mean, CLL, chronic. Okay. And it's asymptomatic. And I'm here with Dr. Schatz. And we don't know what my counts are, but last time it was 63 white blood cell counts.
Last time in October was 67.
Wow. So it used to be 9, and now it's up to 63. And what's your count right now? Your count, white blood cell count?
Well, I don't know, but I assume it's in the normal range, which is
5.
5 or 6. Yeah.
5 or 6. What's your count?
Never checked it.
Oh, okay. So, I mean, that's really scary, Roberta, but Dr. Schatz is thinking that the red blood cells is pretty decent, but the platelets is not.
Well, the platelets are still, again, we don't know today's value yet because for whatever reason they didn't draw your blood on the way in.
Yeah.
But as of last time, their platelets were 120.
Yeah.
Right, which is a little below normal, but not to the point where we worry that we need to treat the CLL. They have gradually, slowly but surely drifted down a bit, so we're going to keep an eye on those.
Yeah, okay.
Okay.
But the red blood cells.
The hemoglobin, the red blood
Hemoglobin,
cells,
yeah.
has always been great. 15.3. 15 is, I know 18-year-olds would want a count that good. So, so that is the thing that drives us to treat this disease, not the white count by itself. The white count is an indication of disease, but the way it affects the other counts is more important. And for you, what's important is that you have what we call good risk CLL, because you have molecular changes that go along with a more indolent kind of CLL, a more slow-growing CLL. And even more important than that is it's been 10 years since you were diagnosed and you have never required treatment. That tells us alone that this is a very indolent CLL that you have. So, so we keep an eye on it. And
Now, as far as this new treatment that my friend Al Stein in California emailed me about,
venetoclax.
that's not what I need right now. The first, if we have a problem in the next few months, Dr. Schatz would consider using chemical treatment.
I would most likely in you, I would recommend an initial combination of chemotherapy along with a monoclonal antibody. Like usually we use this drug called rituximab.
Of course, rituximab, the good old favorite.
Plus chemo. There's now other anti-CD20 antibodies that we use sometimes too, but the most common is rituximab.
Sure.
We can combine it with a drug called bendamustine, which is a chemotherapy drug. We can combine it with a 3-drug combination called FCR.
Yeah.
Or F and C. The R is the rituximab.
Yeah.
Those are 2 different chemotherapy drugs.
Yeah.
Those are both very active frontline treatment regimens for CLL with the goal of putting it into a remission where it basically everything normalizes for a period of usually years. And we put it back on surveillance.
And I'll lose my hair and I won't be able to race my bicycle.
It depends on which one of these we use. The R bendamustine does not make you lose your hair. The FCR usually does.
Yeah.
So, but we're not going to, if the counts are still like they have been, we're not going to do that.
Yeah.
And the reason is, the longer we wait before treatment, the longer it is before we start selecting for cells that are resistant to treatment. Right now you have a lot of cells that are pretty slow growing and are making up most of the disease. If you got to have CLL, those are the ones we want to be around. We'll wipe them out very easily with the treatment, and then cells that are selected to be resistant to treatment are the ones that are most likely to grow back with time. And then it becomes harder to treat each time we have to treat. So by waiting, when treatment is not necessary, we're buying time before we're having to deal with CLL that's harder to treat.
I see what you're saying. So Venetoclax. How do you spell it?
Venetoclax.
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 Okay.
It's a great drug. Very exciting drug.
That was developed in England?
Mostly here in the United States, actually.
United States,
By
okay.
a company called AbbVie.
Okay.
And they have now merged with other companies, and it's become complicated their business structure. But they're I've actually worked with that company a good bit. They're a good company, and they have a very exciting product, which is now approved, but it's approved in the second line setting. For now, it'll probably have wider approvals moving forward, but for now it's approved not for frontline treatment, but for some patients who have failed prior treatment.
So Alan, I won't call you up. You've heard what he has to say about that drug, and when I heard he was from the University of Chicago Medical School, where I went to undergrad, pre-med, I said, well, this is my guy, and so that's why I'm here. And U of C, go Maroons. Billings Hospital.
Yeah, I know it well.
59th Street.
Absolutely.
Oh, the winters are brutal, though.
Sure.
All right, that's about it from here. Ta-ta.